ANEclear provides for a safer and faster emergence from inhaled anesthetics in spontaneously breathing patients. During emergence in your spontaneously breathing patients, an activated ANEclear utilizes partial rebreathing of carbon dioxide to raise the partial pressure of carbon dioxide in the blood. This respiratory stimulant increases the patient's spontaneous minute ventilation, which accelerates clearance of the inhaled anesthetic from the lungs. This same respiratory stimulant, PaCO2, will also increase cerebral blood flow velocity. This is especially important while under the influence of inhaled anesthetics and opioids due to their respiratory depressing effects. Some of these drugs are opioids, benzodiazepines, nitrous oxide, and neuromuscular blocking agents. At 30 liters per minute, ANEclear adds 1.8 centimeters of H2O airway resistance into the breathing circuit. This added resistance minimally increases the work of breathing for a spontaneously breathing patient, as ANEclear is typically a very small percentage of the total circuit resistance. This added resistance is comparable to adding an additional large diameter bacterial filter into the breathing circuit. Emphasis on maintaining adequate delivered tidal volumes of at least 500 milliliters is vital in the safety and efficacy of ANEclear, especially in spontaneously breathing patients. This tidal volume level will provide adequate oxygenation during rebreathing. If tidal volumes are less than 500 milliliters with the rebreathing loop fully extended, it may be possible to continue the use of ANEclear if the patient tolerates tidal volumes less than 500 milliliters. However, special attention should be paid to both the fraction of inspired oxygen and oxygen saturation. If FiO2 drops below 35% or oxygen saturation drops below 90%, ANEclear should be deactivated. In order to obtain maximum benefit from ANEclear in a spontaneously breathing patient, it may be desirable to augment their tidal volume by bagging or using pressure support mode ventilation if available. These methods will increase and optimize minute ventilation. Patients in which minute ventilation is disrupted by excessive coughing could also benefit from synchronous intermittent mandatory ventilation to augment baseline ventilation while supporting spontaneous attempts. Additionally, LMAs in spontaneously breathing patients are less stimulating and can cause less coughing. Therefore, LMAs usually provide for the best environment for maximal ventilation and removal of inhaled anesthetic in a spontaneously breathing patient. Ensure the patient's minute ventilation remains intact when discontinuing SIMV or pressure support ventilation before removal of the LMA. In spontaneously breathing patients, where maintenance and tidal carbon dioxide levels are above 45 millimeters of mercury prior to emergence, activate ANEclear with the rebreathing loop contracted. This will minimize the dead space of ANEclear to 400 milliliters and allow for the clinician to control the amount of partial rebreathing and best manage the extent of hypercapnia. The rebreathing loop can slowly be expanded to increase the amount of rebreathing and levels of rebreathed carbon dioxide when it has been determined that higher carbon dioxide levels can be tolerated. Use a bite block. In vigorous spontaneous ventilation, biting on the endotracheal tube or LMA could greatly increase the chance of a patient experiencing negative pressure pulmonary edema. Discontinuing ANEclear before the patient is completely awake can slow recovery. Monitor your patient for the classic signs of emergence from inhaled anesthesia and extubate based on your best clinical judgment.